Good afternoon, morning, night, whenever you happen to be watching this. I'm Adam, and today I'm going to start covering the section of pharmacology on behavioral medicine. Today, the first section I'll be covering is going to be major depressive disorder. So just a little bit of background. You can't talk really about depression without talking about anxiety with it. We'll actually find that there are different medications used to treat the symptoms of each. But what we do know is that it's a very common mental illness. It's thought to affect anywhere between 10 to 15% of the population at some point in their lives. And we've seen that we've had pharmacotherapy for treating depression and anxiety for some time, since the 1950s. We see that the really early agents, and we'll talk more about some of the problems with them, but they were pretty toxic for the most part. And while they were effective, the side effects oftentimes were the issues that led to a lot of discontinuation of therapy. Fortunately, nowadays, though, we have a lot more selective agents that are much less toxic, and so prescribing of antidepressants and anti-anxiety medications moves strictly from the realm of psychiatry, where you need a lot more specialized training, to primary care. So there's a good chance that you guys yourselves might be prescribing antidepressants one day. Now, depending on their symptomatology, obviously therapy must be tailored to address kind of symptoms of whatever they're experiencing. And sometimes it's kind of difficult to determine really what's going to be the most effective therapy. Interestingly enough, we see that there's a pretty significant placebo effect that occurs with a lot of these therapies they found in trials. Not only that, but it's difficult to compare trials between certain medications due to things like poorly defined outcomes or having good, strong comparative groups and things like that. So a lot of times you're picking therapy not necessarily based on this drug is most effective, but it's more finding what works for your patient. So depression itself can either be unipolar or bipolar. Obviously, you kind of vacillate between periods of depression and mania. And we'll see there are specific medications more geared towards treating bipolar specifically. Typically, you end up seeing females being more affected than males as far as the bipolar depression goes. And along with this, it's important to note that the antidepressants don't work for manic symptoms. So it's really important to realize that polypharmacy is going to be pretty common with this, especially with bipolar patients, because not only are you having antidepressants to treat their depressive symptoms, but now you have to add on a mood stabilizer in order to help prevent the manic episodes and things like that. And so it can be kind of difficult to find a balance that works for your patient between efficacy and toxicity and all of that. Typically the symptoms that we'll see with depression, I'm sure you guys are pretty well aware of this, but you can see things like sad mood, pessimistic worry, depressed interest, and agitation. Oftentimes you can either gain or lose weight. Oftentimes we'll have a decreased energy or libido, and unfortunately we'll have potential for suicidal thoughts. I know this sounds a lot like it could be describing PA school or even pharmacy school for that matter, but again, just remember this is a temporary time period. Things do get better. Now, depression itself may occur secondary to a lot of other conditions, all of which would require their own specific therapy, which we'll talk about at different times in the respective sections. So hypothyroidism, Parkinson's, inflammatory conditions, and just in general, a lot of chronic disease states can lead to symptoms of depression just due to their chronic nature and whatnot. There are actually some agents, some medications themselves that can actually cause symptoms of depression. So we've talked about isotretinoin. While it's a very effective agent for acne, has the potential to cause a lot of kind of mood alterations, and depression can be part of that spectrum. Also find certain anticonvulsants have been linked with depressive symptoms, and even certain cardiovascular agents. These are mostly older agents or agents that are working more working centrally to decrease sympathetic output from the CNS. So you don't see it with things like necessarily, say, lisinopril, but you could potentially see it with something like a guanfacine or a clonidine, something like that. Depression itself is oftentimes underdiagnosed, and to go along with that, undertreated. And unfortunately, and from the poison center side of things, in the toxicology world, we do see a lot of these patients who do end up to try to commit suicide, oftentimes with the medications that you've prescribed to treat their depression. As far as anxiety goes, it's included as a component of many conditions. So there's, generalized anxiety disorder, obsessive compulsive disorder, all these different things. Post-traumatic stress disorder. Anxiety can kind of creep up in a lot of different ways. And we'll see that the therapy is often going to be initiated for symptoms when they kind of interfere with normal function in day-to-day life. And a lot of times this anxiety is going to be associated with their depression, kind of go hand in hand. So, how does depression happen? Quick answer is we don't really know. There's been lots of theories out there, and a lot of them have centered around monoamines within the CNS, and originally thought to be due to depressed levels of these monoamines. So the big ones we'll be talking about today are going to include serotonin, which would be abbreviated as 5-HT, that stands for 5-hydroxytryptamine. There is norepinephrine, which will be abbreviated as NE, and then dopamine. This will become more important when we talk about things like schizophrenia and whatnot, but that will be abbreviated as DA. So one of the reasons why we thought that the monoamines are really, really important, and the depressed levels being important in development of depression, is because we actually had a drug. It's a very old antihypertensive called reserpine. And what this drug basically did was cause all of your neurons in the CNS to basically fire off all of their monoamines, basically just spit out all of their norepinephrine and serotonin and all these different things, and basically depleted the neurons of their monoamines. They get spit out to the synapse, they'd be metabolized by things like monoamine oxidase or COMT and things like that. And what happened when patients were receiving this drug is they actually found that about 15% of their patients actually had development of depression. So they kind of saw this correlation here of depleted monoamines and depression happening here. So that's kind of where the first theory came from. Some of the things to note with antidepressants, though, are that the effects are not immediate. Even though some of the drugs we'll see have a pretty close to immediate effect on increasing levels of monoamines, especially if they're things like inhibiting metabolism or if they're preventing reuptake of the monoamines, they still take a while to work. And this is again going to be one of those big things that we educate patients on, is that a lot of the therapeutic effects of these antidepressants take weeks, sometimes 6 to 8 weeks before we can really say that a drug is not effective. So that kind of led us to think that, well, maybe it's not necessarily just the level of monoamines, but perhaps there are some downstream effects that we're looking at. So maybe there are things like receptor occupancy. Maybe that has something to do with depression. Or maybe gene transcription in response to these altering levels of monoamines. And so now kind of what we're focusing on is more looking at the adaptive and regulatory changes that are occurring when you have these altered levels of monoamines versus simply the quantity of them. So really there's no final theory on how antidepressants work, but we do know that they do work based on clinical trials and whatnot. So our goals of therapy for treating depression, one, we'd like to reduce the symptoms of acute depression and help the patients kind of facilitate their return to a normal level of functioning. And then hopefully we can prevent further episodes of depression from occurring. So this is kind of the goals of what our drugs are going to be used to accomplish. It kind of breaks down into a couple of different phases of treatment. The initial one being the acute phase, which can last anywhere between 6 to 12 weeks. This is where the drugs are initiated or other therapies, and this is kind of the lag time before things really kick in. So that's why it kind of starts at 6 weeks. Hopefully here we're having remission of symptoms, and then there's this continuation phase from around 4 to 9 months or so where you are hoping to eliminate some of the residual symptoms, and hopefully they are sticking with whatever therapy has worked for them, and this will help to prevent recurrence. Something you may potentially see is patients will start to take, say they're taking an antidepressant, their symptoms get better, and they think, wow, I'm cured, and then they stop taking it. And that was oftentimes what can lead into remission, especially with some of the kind of withdrawal effects that you can see with these medications that we'll talk about a little bit later. hopefully if they make it through the continuation phase, then they should get to their maintenance phase, 12 to 36 months after, and really the goal here is to prevent recurrence. Oftentimes this is going to require lifetime therapy. Unfortunately, we don't have the magic bullet for curing depression, and oftentimes you'll see patients who have recurrent symptoms, so 2 to 3 or more prior episodes. Those are more likely the patients that are going to be requiring consistent therapy throughout the rest of their lives. And this is why adherence and patient education are so critical, because they don't, at the importance of the stress, it may lead to, discontinuation of the drug, and can lead to all of a sudden their symptoms start to flare up again. So that's what we're trying to avoid. Looking at non-pharmacologic therapy, we do see that psychotherapy is still very effective, and the effects are typically going to be additive with antidepressants. So certainly we can see some synergism here, and by utilizing the psychotherapy along with pharmacologic therapy. I know as shocking as it is, electroconvulsive therapy, or ECT, is still a possible method for treatment of depression, and some of the newer things down the pipeline include things like repetitive transcranial magnetic stimulation, or rTMS. Actually, I have a friend who was a paramedic who was working in a kind of a natural health kind of office where they had one of these setups, and actually said it was pretty effective. Essentially, they're putting a magnet onto the front of your head and are kind of beaming these magnetic signals through. Obviously, that's not a very technical explanation, but he did see some pretty decent effects. So obviously, you do your own research to determine that, but I'll stick with the medications for now. So moving into pharmacologic therapy. So as I alluded to before, with antidepressants, unfortunately we cannot predict which agent a patient is going to respond to. Oftentimes we're going to see that the choice is going to be made more empirically. So we want to see, has the patient been on something previously that they've responded well to? If they failed a specific type of category of drug, perhaps don't go with that. Let's try something different. Looking at concurrent medical illnesses, we can see where certain disease states can be exacerbated by some of these medications, so that could be a consideration. Look at their presenting symptoms. Do we need to treat the anxiety component, or is it mainly just the depressive symptoms we want to look at? Look at the cost of therapy. Obviously, if the patient can afford their medication, they're not going to be able to be very adherent to it. Then also looking at drug-drug interactions, which can be very important, potentially even life-threatening in some cases. Also look at the adverse reaction profile. Obviously, we'll see with some of our older medications that the adverse reactions were pretty significant and pretty common, but still, even with some of our newer medications, that is still a possibility for sure. And then finally, patient preference. Again, if the patient is not able to tolerate the medication for whatever reason, doesn't want to take it, then that's going to be a deal breaker. So we need to find something that the patient is going to respond well to, that they are okay with taking. So the way that we're going to be classifying the antidepressants is partly on its chemical structure, and then for the others it'll be on a presumed mechanism of action. So we'll see that even though they have a direct mechanism of action, that because of the downstream effects that we were looking at before, we know that simply the level of monoamines is not enough to explain the antidepressant effects. We know that these mechanisms of action are not directly linked to the therapeutic effects. But by knowing their mechanism of action, it does help us to understand the expected adverse effects, which is directly related to this mechanism, and we'll certainly get more into that as we move forward. So again, with antidepressant therapy, you need to have a trial of at least 2 to 6 weeks of therapy for full therapeutic effects, potentially even up to 8 weeks in some cases. Because the adverse effects are typically due secondary to the drug's mechanism of action, that these adverse effects should occur more quickly, so within hours to days. Some of them may diminish over time, some may stick around for the duration of treatment. And that's kind of the problem, is that patients are starting these medications, they're depressed, they're anxious, and now all of a sudden they're having all these adverse effects where they're still depressed and anxious. So oftentimes this is a big reason why patients will end up quitting therapy early. Now, actually looking at pure failure rate, not necessarily due to compliance, about 20 to 30% of patients will fail with antidepressant therapy. Looking at it, there's a few different reasons. Some patients may be intrinsically resistant to specific types of therapy. Not necessarily for any one reason or another. Could be due to pharmacogenetic differences, which, as we remember, could be due to specific polymorphisms of different genes that the patient has, may lead them to respond well to one type of drug while they have no response to another. Could be related to inadequate drug dosage or duration of therapy, or could potentially be due to non-compliance. So again, this could be related to adverse effects or delay in therapy, say they have problems paying for it, things like that, that lead them to not actually take the drug as prescribed. Another kind of confounding factor is that in certain trials, they've actually even seen that there's a pretty heavy placebo effect component here, where in some trials, between 30 and 40% of patients who were randomized to placebo had natural remission of their own symptoms within 6 to 12 months. So we know that even though a patient is having an acute episode, even doing nothing, the episode may resolve on its own. But a lot of these patients do end up having recurrence of symptoms. So the idea is by having antidepressant therapy on board, perhaps you can avoid some of these remissions from occurring in the first place. So then looking at some of the classes of medications, the tricyclic antidepressants, which will be abbreviated as TCAs, and then the selective serotonin reuptake inhibitors, or SSRIs. We'll see that there's not a great difference in their efficacy for treating the symptoms of depression, but they certainly do differ in their adverse effect profile. That goes for both at therapeutic doses, where you see just normal adverse effects pop up. The TCAs and older agents typically are going to have a much lower toxic index, as we mentioned before, where that dose between where it's effective and where the toxicity starts in is going to be a lot lower than you see with something like an SSRI. It has a much larger therapeutic index, versus an overdose as well, where TCAs very, very lethal, whereas SSRIs you have to take quite a bit before you even see the issues, which can mean a life or death kind of situation for your patient, depending on what they've overdosed on. So looking at the different major categories of antidepressants, you'll see at the top we have kind of the older agents. These are more non-specific type of agents in their mechanism of action, as we'll mention in more detail. And then as we go further down, you're going to see they're more selective, newer agents. So kind of the first group we were looking at is the monoamine oxidase inhibitors, or MAOIs. Basically what they're doing, the name kind of says it all, they are preventing the breakdown of catecholamines by inhibiting this enzyme monoamine oxidase. So by doing that, by preventing their breakdown, you're going to have a higher concentration in the synapse of 5-HT or serotonin and norepinephrine. Kind of after that, we had tricyclic antidepressants, or TCAs. These work by inhibiting the reuptake of both serotonin and norepinephrine. So we'll see a picture of that in a second, where you can actually see that on the presynaptic side, there is a recycling process that occurs with a lot of these catecholamines, or these monoamines, and by interrupting that, you can increase concentrations of the monoamines in the synapse. After that, we had the selective serotonin reuptake inhibitors, or SSRIs, and these work a little bit more specifically than the tricyclic antidepressants do, because they inhibit the reuptake of just serotonin instead of working on norepinephrine as well. And then finally, with the newest set of agents, we had the selective serotonin norepinephrine reuptake inhibitors, or the SNRIs. Again, similar to TCAs, they inhibit the reuptake of norepinephrine and serotonin, but as opposed to the TCAs have a much dirtier receptor activity profile. Mostly they have a lot more activity at things like the cholinergic, the muscarinic receptors. They work at alpha receptors, all kinds of different places that lead to a lot of the side effects. The SNRIs don't really have any of these problems because they work specifically to block that reuptake. So looking here at this picture, we have a couple of neurons, a couple synapses here. Get my laser pointer. So looking here at the different ways, so again, this is going to be the postsynaptic neurons. These are going to be the presynaptic neurons. Looking here on the top, we have a noradrenergic neuron, which would be releasing norepinephrine, so you can see right here. And then you'll also have the serotonergic neurons, which are going to be releasing 5-HT, or 5-hydroxytryptamine, and serotonin. So looking at the first group of medications, the MAOIs, and the monoamine oxidase inhibitors, after norepinephrine has been released, it's going to get retaken up by the presynaptic neuron through some of these transporters. So this norepinephrine transporter. On the serotonin side, the same thing's going to happen through a serotonin reuptake transporter. Once these get retaken back into the presynaptic neuron, we're going to see that normally monoamine oxidase would be responsible for metabolizing those monoamines. By inhibiting this enzyme, you're going to have a higher concentration of the neurotransmitters, thus higher concentration going to be released into the synapse where they can have their downstream effects of hopefully fixing their depression. We'll also see on the TCA side, TCAs and both SNRIs are going to be working on the norepinephrine reuptake transporter to inhibit the reuptake of norepinephrine. So by blocking this process here, there's going to be a lot more norepinephrine in the synapse, leading to downstream changes. And then on the serotonin side, you'll see that SSRIs, TCAs, and SNRIs are going to be working on the serotonin transporter. Again, blocking this is going to increase concentrations of serotonin in the synapse, and again, all of that will lead to downstream changes. So essentially, that's how they function. It gets a little bit more complicated than that, but that is at the basis level how the drugs are specifically working. So again, looking at their mechanisms of action, in general, they're going to be enhancing the norepinephrine and serotonin effects. So again, by increasing the concentrations, whether by inhibiting breakdown or preventing the reuptake. And again, we don't know their full mechanism of action due to these downstream changes. We are pretty sure that long-term therapy is going to help to lead to a lot of adaptive and regulatory changes. So some of the things we're hoping to see, or some of the things we think might be important in the treatment of depression, would include things like changing the receptor density for serotonin and norepinephrine, perhaps seeing some increased secondary messenger signaling. So again, those G proteins might be more active or more plentiful, and maybe even some downstream gene products. So again, increasing transcription of some of these proteins like brain-derived neurotrophic factor, BD and F, by increasing transcription of that. Perhaps that is leading to some of the changes we're seeing when we have alleviation of depression. So the initial antidepressants actually have kind of an interesting start. We'll start with the monoamine oxidase inhibitors, since they were the earliest agents. Kind of started out with iproniazid. It was the first agent that came out. It was actually an anti-tuberculosis agent. What they actually saw was in patients they were treating for tuberculosis, they were actually seeing some elevated mood in some of the treated patients. So from that, we end up having development of things like phenelzine, isocarboxazid, and tranylcypromine. Some of the problems of these earlier agents is that they were actually irreversible inhibitors of monoamine oxidase A and monoamine oxidase B, basically two versions of monoamine oxidase. And again, they were affecting the metabolism of serotonin, norepinephrine, and dopamine. Some of the other problems that we're seeing too is that tyramine, which is an exogenous monoamine that is actually found in lots of different foods, that led to additional production of some of these monoamines. It led to a lot of adverse effects, which we'll talk about in just a little bit. But essentially with monoamine oxidase inhibitors, one of the biggest things we'll see is that food-drug interactions is going to be the big thing to worry about. Again, we'll see that phenelzine, tranylcypromine are some of the more common ones you'll see, but again, a lot of these drugs have kind of gone by the wayside. But you will still see selegiline transdermal. MSAM is the brand name for that one. This one's actually more often used for Parkinson's disease. Once we get to that section of neurology, we'll talk about why that is. So looking at the adverse effects, one of the biggest things we're going to see is due to postural hypotension. Basically, this is due to kind of an inability to regulate catecholamine flow, which again, catecholamines are really important for, especially norepinephrine, for affecting the alpha receptors to manage blood pressure. So postural hypotension, huge thing we're going to see here. So especially in your older patients, chances for falls and things like that. We also see weight gain and a lot of sexual side effects. Something you'll see that's fairly common with a lot of our antidepressants, so decreased libido and anorgasmia. So maybe you were depressed before, but now that you have this decreased libido, maybe it's a new source of depression for you. So obviously a lot of these side effects can be deal breakers for some of your patients. And then one of the biggest problems we saw is that due to the fact that we're having less metabolism of some of these catecholamines, that especially when you had exogenous foods that would contain tyramine or other drugs that enhanced the effects of catecholamines, you run the risk of developing this hypertensive crisis. Most oftentimes it'd be noticed with things like headache, nausea, vomiting, diaphoresis, and stiff neck. In some cases, would even lead to cerebrovascular accidents and death in some cases. One of the problems, though, is that looking at these irreversible inhibitors of monoamine oxidase is that just because I stop taking the drug doesn't mean that all of a sudden my monoamine oxidase starts working again. Because it's an irreversible inhibitor, what we end up seeing is that you can still have symptoms up to 2 weeks after discontinuation of the drug, because that's how long it takes for the body to regenerate its own enzymes. If you were to have this issue, obviously you would just treat with antihypertensives, whether it be beta blockers or alpha blockers, different things are going to be available. But that was one of the biggest problems that we saw with therapy with the MAOIs, is this risk for hypertensive crisis. So the foods that you will most often see being interacting with the monoamine oxidase inhibitors are going to be those that are high in tyramine. So that is going to include things like aged cheeses, sour cream, yogurt, cottage cheese. Also red wines like Chianti and sherry are particularly high in tyramine. Included that is some beer. Aged or processed meats, MSG, fava beans, soy sauce, all of these things are very high in tyramine. So basically all of the best foods are going to be kind of off limits had you been someone taking a monoamine oxidase inhibitor. So again, big component of drug interaction, food-drug interactions happening for your patients who are not going to be compliant to this. A lot of medications that could also interact with this that would enhance the effects of catecholamines would include things like amphetamines, appetite suppressants. All of these are kind of pro-sympathetic nervous system type agents, asthma medications, cocaine, decongestants. All these other things were kind of exacerbating the effects of the monoamine oxidase inhibitor. Lots of other drug interactions, but those are the main ones you'd be worried about with MAOIs. So we know that it was kind of fraught with problems, so we said, well, we need some better agents, and so we were able to generate the tricyclic antidepressants. And so these guys are actually derived from the phenothiazines, which we'll talk about when we get to talking about schizophrenia. So the phenothiazines are a class of antipsychotics, and so TCAs are actually kind of a derivative of that. Again, they're going to be affecting that serotonin reuptake transporter and the norepinephrine transporter. So essentially what you're going to be seeing is going to be increased levels of serotonin and norepinephrine in the synapse. Again, these used to be first-line therapy, but since the SSRIs typically have a much better adverse effect profile, TCAs have gone by the wayside for a lot of cases. Unfortunately, though, TCAs are still widely available due to the fact that they can be used for other things. So we'll see that TCAs are very sedating. So a lot of times they're being prescribed as needed for insomnia, or potentially even being utilized due to the norepinephrine effects. We actually see some benefits from using these for pain conditions. So these can be useful for treating some neuropathic pain problems. The reason why I say unfortunately is because from a toxicology standpoint, these drugs are very, very difficult to manage, very scary, and overdose. And so this is one of those things we like to see less and less use, if possible, of this drug. So some of the available agents are going to include amitriptyline, desipramine, doxepin, imipramine, and nortriptyline. You'll see these as the more common ones. It's not to say that this list is completely inclusive, but certainly these are ones you're more likely to see in normal day-to-day patient care. So looking at the adverse effects, TCAs, like I said before, have the habit of affecting lots of different receptors. So one of the big things we're going to see is a lot of side effects are related to this receptor activity. So one of the big things we're going to see is that the anticholinergic effects, the big cause of a lot of symptoms. So this is related to TCAs blocking muscarinic receptors, so preventing acetylcholine from activating them, and we get this anticholinergic toxidrome. Essentially what we're seeing here, it basically is described as a mnemonic, mad as a hatter. So you can see some sedation at normal therapeutic doses. As higher doses are achieved, especially if they were taken as an overdose, you can see things like agitation, hallucinations, and seizures. So that's where we get that term mad as a hatter from. Blind as a bat. So they will be complaining potentially of blurry vision. You'll see they'll have very wide mydriatic pupils. Hot as a hair, potentially hyperthermia, you can see there. Dry as a bone. So they will, basically the antimuscarinic effects are going to dry up a lot of secretions to where they might be complaining of urinary retention or dry mouth, which can be an issue for your patients. Also has a habit of slowing down GI motility, so potentially you can see things like constipation or nausea, vomiting associated with that. Red as a beet, so it can cause some flushing, and then oftentimes you'll see tachycardia associated with these muscarinic effects. Not only that, but especially in overdose, we can see that they will also block sodium channels on the heart. And so by doing this, you see very similar to our 1A antiarrhythmics that we talked about previously, so quinidine, precanamide, disopyramide. Those also work by blocking sodium channels, and so what you end up seeing is a widened QRS and chance for dysrhythmia. They also are going to block alpha receptors, so especially on the peripheral vasculature, you can see hypotension develop. And very similar to what we saw with the MAOIs, you will also see sexual dysfunction and weight gain as a side effect. And then from the antihistamine type actions, so very similar to how you would see with our first generation antihistamines used for things like allergy relief and things like that, you will see sedation here as well. So again, sedation is pretty commonly seen with this, and again why it's oftentimes prescribed for sleep. Usually at lower doses than for depression, but certainly you'll see it quite often being used as needed for sleep. Moving on, then we have our SSRIs, and again these are specifically working to block that serotonin transporter. So again, by being more focused, by being more active at just one site instead of affecting multiple receptors, we're going to see these increased levels of serotonin within the synapse, but hopefully see a lot less side effects related to that. And so nowadays they've actually become first-line therapy for major depressive disorder. One, because they're going to be much more tolerable, so much fewer side effects patients have to worry about, and they also have the benefit of having a much wider safety margin, so they're a lot safer in overdose. It's very difficult to kill yourself with a pure SSRI overdose versus with a TCA, where even a few times over the therapeutic dose can be pretty toxic. With a TCA. SSRIs, you can take a whole bottle and potentially not really do a whole lot of damage, so to speak. But we can talk more about that when we get to the tox section later in the semester. So some of the agents available here are going to include citalopram, or Celexa, and the enantiomer of that, escitalopram, Lexapro. Remember, as we said before, that some drugs are basically chiral molecules, or racemic mixture, and have chirality to them, so they're left and right-handed molecule. Escitalopram is basically the left-handed side of that citalopram. So by kind of partitioning that out, the idea was you'd have a drug that potentially has less side effects and is still as effective. I will tell you that a lot of time it does seem that drug companies tend to come out with these enantiomers right as the patent's about to run out on the parent molecule. Take that as you will, but those two are very similarly related, especially in side effect profile. Next you have fluoxetine, which of course is Prozac, fluvoxamine or Luvox, paroxetine, and sertraline are all agents that would be classified as an SSRI. So looking at the adverse effects associated with the SSRIs, we'll see that they, because they're more specific for working on that serotonin reuptake transporter, they do have a lot lower affinity for working against alpha receptors, histaminic receptors, muscarinic receptors. So because of that, there are a lot fewer side effects associated with them, and they're a lot better tolerated than we saw with a lot of our older agents, specifically the TCAs. We also see less weight gain associated with them. But most commonly, what you will see is GI upset. You'll certainly still see some sexual disturbances occurring, headache, and insomnia. There's also the issue of having a discontinuation or withdrawal phenomenon. This most often occurs with abrupt discontinuation of the drug. So what can happen is basically, especially when you have a shorter acting agent, with abrupt discontinuation, your brain's kind of used to having that extra serotonin around. So if all of a sudden you cut that off, very similar to how you see withdrawal effects from things like opioids or things like cocaine and things like that, your body's kind of not used to operating at that level anymore. So it's because of that, you're going to have these withdrawal symptoms. So we see things like anxiety, increased anxiety over what they might have had before. See some sleep disturbances, and increased risk for having symptoms of depression recur. So the idea would be to prevent this, you want to taper your dose pretty slowly, similar to how you would do with, say, a corticosteroid. If you've been treating for a while, you want to slowly taper off your dose over the course of several weeks. One of the things that we can see, one of the ways we can kind of head this off is for specialty patients who you're worried about compliance being an issue, is to use an agent with a longer half-life or one that has active metabolites. So a good example of this would be fluoxetine or Prozac. By using one that has a longer half-life, it kind of has a natural taper to it, to where the levels kind of naturally decay a lot slower than you would see with a shorter acting agent. And so by doing that, you kind of prevent some of these withdrawal symptoms from occurring, or maybe keeping them from being quite so severe. So this might be better for your patients who are more prone to, say, missing a dose or two, because this is going to help prevent a lot of those withdrawal effects from happening. Interestingly enough, in my training, I actually saw a baby in the NICU who is actually suffering from withdrawal symptoms because the mom had severe depression and required treatment throughout the pregnancy. So when the baby was born, all of a sudden it was cut off from its source of SSRI and then started to have these withdrawal symptoms. So the baby wouldn't sleep well, was not eating, was very, very irritable. And so it was actually kind of a difficult to manage patient because, again, you don't necessarily want to start the patient back on an SSRI just to replace what the mom was inadvertently giving her. So something you may see in your line of work, especially dealing with pregnant patients. And again, we know that the pregnancy blues is certainly a real phenomenon. Now, the SSRIs, one of the benefits in addition to treating depressive symptoms is that they may actually help to improve some of the anxiety symptoms as well. For some patients, it might actually have worsened symptoms, but I generally see that the anxiety is helped more than anything with the SSRIs. Of note, of particular kind of side note with citalopram and escitalopram, these are unique because they will actually have the potential to cause QT prolongation. So something unique to these guys is that, especially in overdose, we can end up seeing QT prolongation and the risk for torsades develop with these two agents in particular. There's also a black box warning that was put on for SSRIs, and this is for suicidality. So seems kind of counterintuitive that a antidepressant would have a black box warning for suicidality, but they've actually seen that in some studies with children and adolescents that there's an increased risk of suicidality in children, adolescents, and young adults. We don't necessarily know what all of the we don't necessarily know the reason why this is, but some possible mechanisms that people have been kind of postulating is that one is that, initially when you're taking these SSRIs, usually during a depressive episode, the patient has a depressed depress energy levels. So even if they wanted to kill themselves, they really just don't have the energy to act on those thoughts. One of the things we see with the SSRIs is that with the initial, especially early on, before the drug has really had effects on the depressive symptoms, they can have an increased energy. And this is kind of described this term akathisia. You see more with antipsychotics, but you can see it with SSRIs as well, where it's basically kind of this kind of sitting, squirming in their seat, kind of this increased energy, but not really anywhere to apply it. And so in some depressed patients, this may actually lead them to acutely act on their suicidal thoughts. Other people may think that this applying an SSRI may actually kind of take care of a depressive symptom, but accidentally lead to uncovering a manic episode in bipolar patients, which sometimes the suicidality can come out more prominently during the manic episodes. So who knows, but it's certainly black box warning is certainly something to consider before putting your, especially younger patients, on an SSRI. And then finally we have the SNRIs, which are going to be kind of the more new agents. Again, these are non-tricyclic antidepressants, but they are going to be less specific than the SSRIs, and they're going to work on both the serotonin reuptake transporter and the norepinephrine reuptake transporter. Fortunately, because they're not working on things like the muscarinic receptors or the alpha-1 receptors and things like that, they're going to see a lot fewer side effects than the TCAs. And due to the norepinephrine reuptake effects, they have some efficacy for treating some pain conditions, especially neuropathic pain conditions. So sometimes you'll see some of these SNRIs being utilized for fibromyalgia or other peripheral neuropathies due to the norepinephrine effect specifically. Some of the agents that we'll see used most often will include venlafaxine or Effexor. We have desvenlafaxine, which again is going to be kind of one of the enantiomers of venlafaxine, known as Pristique, and then you have duloxetine or Cymbalta. The adverse effects you're going to see with these are going to be fairly similar to the SSRIs. You're going to see nausea and GI disturbances, maybe a little bit higher than in the SSRIs, and you still are going to see the sexual dysfunction. One thing to note, though, especially with venlafaxine, is since they are increasing levels of norepinephrine in the synapse, that has a prosympathetic effect and can lead to increases in systolic blood pressure. And then with duloxetine specifically, you can see dry mouth and constipation, just maybe a little bit of anticholinergic effects, but not to the same extent as you would see with something like amitriptyline or other TCAs. A couple other kind of miscellaneous agents. We have some mixed serotonergic agents. So the two here in this group would include trazodone and nefazodone. Trazodone's brand name being Deseril, and then nefazodone being Vibrid, or Vibrid, however you want to pronounce it. So the way that these are going to work is that not only do they block the reuptake of serotonin, but they are also going to act as antagonists at the 5-HT2 receptor. Unknown necessarily why this will lead to any increased efficacy for depression, but this is where these drugs were originally used. As far as side effects go, you'll see that trazodone specifically is going to be blocking alpha-1 receptors, which can lead to dizziness and hypotension, similar to what we saw with the TCAs. And then we actually see with nefazodone cases of liver failure, which has led to a lot less use of it. So you'll certainly see trazodone being utilized. Typical adverse effects, but this will include hypotension, dizziness, and sedation. So I see trazodone being used with some regularity for being used for sleep. And one of the kind of very hallmark side effects of trazodone use, and this is related to the alpha-1 receptor blockade, is you're going to see priapism as a potential side effect. As odd as it sounds, this is one of those things that always should stick out in your mind because this could be a significant urologic emergency that needs to be acted on pretty immediately. So good counseling point for your patients. Then we have bupropion, or Wellbutrin. This one acts through a couple of different mechanisms. It's going to work to inhibit the reuptake of norepinephrine and dopamine. So you can see a little bit different activity here. This doesn't really have any effects on serotonin, but is still effective for depression. And it may also help to enhance the release of norepinephrine and dopamine as well. So kind of dual mechanisms here for this working. Interestingly enough, we also see bupropion being utilized for smoking cessation. There's actually a brand name that's marketed specifically for that. So Zyban would be the brand name for that. Some of the adverse effects associated with this are going to include similar things to what we've seen with other agents of nausea, vomiting, tremor, insomnia. Specifically with this one, though, there is dose-related effects with causing seizures and arrhythmias. So especially an overdose, it's going to be very, very significant. So again, it's maybe something to avoid if you have patients who maybe have had previous episodes of suicide, things like that. Some patients may become a little agitated, but one of the big reasons why bupropion gets utilized pretty frequently for depression is due to the fact that it has less sexual dysfunction than other SSRIs. So again, if your patients are complaining of this, if this is kind of a deal breaker for their compliance, this is probably the drug you want to prescribe for your patients, as this may lead to a lot less incidence of that. Another one of the miscellaneous category is going to include mirtazapine or Remeron. This one is going to be an antagonist at presynaptic alpha-2 autoreceptors. So we've seen other drugs that work at the alpha-2 receptors, but we've actually seen agonists before. So if you guys think back to clonidine back in your antihypertensive lecture, clonidine is actually an agonist at the alpha-2 receptor. What that did on the presynaptic neurons is by activating this autoreceptor, it was able to decrease the flow of catecholamines. Here with mirtazapine, this is going to be an antagonist at the presynaptic alpha-2 receptor, so this will actually end up increasing release of norepinephrine and serotonin. Not only that, but it has the ability to antagonize the effects of serotonin at the 5-HT2 and 3 receptors, and also has some antihistaminic actions as well. Typical side effects we're going to see with mirtazapine include somnolence, weight gain, dry mouth, and constipation. Again, with some of these miscellaneous agents, they're probably not going to be used first line. Certainly the SSRIs are probably the first line agents to go to, but if they have treatment-resistant depression, these might be good agents to may fall back to. One of the big things that we worry about anytime a patient is taking a serotonergic medication is this phenomenon called serotonin syndrome. So any agent that increases serotonin can be associated with this. It can happen at therapeutic doses, especially if patients are very sensitive to this. Can also happen in overdose as well. Interestingly enough, one of the odd cases of serotonin syndrome that I remember seeing was actually when, especially anytime you're combining multiple medications that are working to increase levels of serotonin, anytime you can see that. So certainly, patient takes an overdose of multiple antidepressants, it can happen, but an interesting one is where a patient was receiving methylene blue for a parathyroidectomy. Essentially, parathyroid hormone, methylene blue gets preferentially concentrated in the parathyroid glands, and so the surgeon was using this to kind of isolate those so they can be resected. Well, turns out methylene blue actually has the ability to inhibit monoamine oxidase, and so the patient happened to be on antidepressants, happened to be on SSRI, and so this mixed with the MAO activity of methylene blue actually precipitated serotonin syndrome right in the middle of surgery. So the patient ended up having altered mental status, hyperthermia, some autonomic instability, which can be things like tachycardia, hypertension, but could also be bradycardia, hypotension. And typically you're going to see some sort of increased muscle tone. So you can see clonus. In very severe cases, you can typically see rhabdomyolysis develop, or the really severe muscle breakdown. And so oftentimes you're having to rule out other causes for this toxicity, because it can look like a lot of other things. Could potentially look like things like sepsis, could look like other drug ingestions. So kind of once you've ruled out everything else, you might consider serotonin syndrome. But essentially, it can occur anytime with multiple serotonergic medications on board, or it can include if you had, say, something like an MAOI on board, and you had increased levels of tyramine intake from diet, it can certainly precipitate that. Certainly the drug linezolid, or Zyvox, which we know is used to treat very resistant gram-positive infections also has some activity at blocking monoamine oxidase, so there's been cases of serotonin syndrome linked with that drug being mixed with SSRIs. So again, we kind of discussed a little bit about the symptoms we're going to be looking for, but you can definitely see things like sweating and hyperthermia, altered mental status, rhabdomyolysis, all kinds of the whole spectrum here. Management is basically going to be really just aggressive supportive care, lots of hydration with IV fluids, some evaporative cooling to help manage the hyperthermia, and then potentially cyproheptadine, which is an antidotal agent. It's actually a first-generation antihistamine. You'll probably most often see it being used for appetite stimulation. Brand name is Periactin. But it actually has some serotonin blocking effects as well, so you can actually give it to block the effects of serotonin and help to limit some of these effects. So, looking at the pharmacokinetics of some of these antidepressants, I know this is probably one of your favorite topics, but it's important to consider when you're selecting drugs. So, again, agents with longer half-lives or active metabolites, so fluoxetine kind of being the prototypical SSRI with very long half-life, is going to be better for patients with compliance issues. So if you know that they're more prone to missing doses or just to stop therapy altogether, this is going to help with that, because just because they missed a dose or two does not mean that they will have immediate withdrawal effects. So again, by using these drugs, you may not need as long of a taper or even a taper at all because of the fact that the half-life is so long. But certainly, the thing to consider is that when you're adding on a new medication, you don't want to just stop taking fluoxetine and all of a sudden, the next day start taking escitalopram. You need to give it time for it to work out of the system. So some patients will require, say, a few days to a week before switching over to a new agent. Again, this is to help decrease the serotonergic toxicity you can see by having too much of these drugs on board. So it can be kind of a delicate process when switching agents. Again, the chronic therapy is going to lead to tissue accumulation. So again, therapeutic effects can appear to be much longer than with that apparent half-life. So again, just with a lot of other drugs, taking it for a long period of time, you're going to have tissue buildup, and that's going to lead to kind of slow leaching for a time after the drug has been discontinued. And also, a lot of these drugs are mainly going to be metabolized by the liver. Not a ton are ever going to be exclusively renally eliminated. So because of that, you can see, especially in patients with poor liver function, especially in cirrhotic patients, some of the half-lives of these may be extended to several times normal. So some of those you may either need to decrease the dose significantly, or potentially even you give maybe every other day dosing instead of daily dosing. Looking at therapeutic monitoring, we know some drugs we can utilize drug levels in the serum as a surrogate for efficacy, but unfortunately, since we don't know necessarily of any good correlation between drug levels and therapeutic efficacy, these are not really going to be all that useful. So really, the drug dosage needs to be titrated over time based on their symptomatic response. And keep in mind that the full effects are going to take up to 6 weeks to really see the full effects. So you don't want to start increasing your dose at week 2, because we don't know necessarily that the drug's not effective at that time. It could just be that it's still taking time to work. And the only thing we're going to do by increasing the dose too prematurely is potentially increase their risk for toxicity. So again, this is really important for educating your patients and making sure they're aware of the delayed effects. Other things to consider would be drug interactions. We see that newer agents, especially things like venlafaxine, duloxetine, and bupropion, typically are going to have fewer pharmacokinetic interactions to have to worry about. And for the most part, the SSRIs and the newer agents have somewhat variable effects on CYP enzyme inhibition. Not a lot of these have very significant effects, so that's kind of a benefit for, especially when they're on a lot of other medications, especially for hypertension or hyperlipidemia and things like that. Now, TCAs specifically are going to be metabolized extensively through the CYP enzyme, so it's always really important to look up their drug interactions prior to prescribing, because again, if you have a significant CYP enzyme inhibitor on board, prior to administering a TCA, you can end up increasing their half-life pretty significantly and leading to toxicity. So because of that, certainly look up their profile beforehand to look for any potential drug interactions, and if so, start low and gently titrate the dose up over time. Some of the TCAs are highly protein bound. We know that that becomes an issue when you have other items trying to bind to those proteins. So what that can do is kick the TCA off of the protein and cause you to have a higher free fraction of drug. We know that free drug is going to be pharmacologically active drug. So the higher proportion of drug that's active or free is going to be more active and thus potentially lead to toxicity. And then any drug that's going to be affecting serotonin may contribute to serotonergic toxicity, as I've said before. Again, serotonergic toxicity is, serotonin toxicity is kind of a spectrum where you can have mild effects like nausea, vomiting, all the way up to the full-blown serotonin syndrome. So again, it's a spectrum. Patients aren't always going to fall into one category or the other. But again, like I mentioned before, linezolid has some MAOI-type actions, methylene blue, and then you can also see some problems with the triptans. We'll talk about migraines a little bit later in the semester, but these are 5-HT receptor agonists. So these include things like sumatriptan or imitrax, rizatriptan, almotriptan. By activating 5-HT receptors, it's going to be synergistic with the activity from the increased levels of serotonin from the SSRIs. Thus, you can see where the serotonergic toxicity can come from. So typically, you see that for a lot of these, you're going to require an antidepressant washout period. So say, for instance, you needed to treat a patient, say you're in the ICU, and your patient has vancomycin-resistant Staph aureus, and you need to use linezolid. Well, some patients actually are going to require a 2-week washout period before starting it because of how significant the MAOI activity is leading to serotonergic toxicity. So it can be kind of a therapeutic challenge depending on the situation and what type of drug you need to use. Other things to look at include QT interval prolonging agents, so especially with citalopram and escitalopram. Again, good ones to remember as causing QT prolongation. They can interact with other drugs that do the same, so again, some of our antipsychotics will be causing this, and also some antiarrhythmics. And then for some of these agents causing sedation, especially the TCAs, again, this can be a kind of synergistic effect, especially with benzodiazepines, which are frequently prescribed for anxiety, and also alcohol as well. So again, if you're taking your trazodone or your maybe your amitriptyline for sleep, and you have a couple of drinks with it, you can definitely see some pronounced sedation occur with that. One other thing to point out from the dietary supplement side, from the herbal side, you have St. John's wort. I'm sure you guys have heard about this before, but it's an herbal supplement that actually has some fairly decent efficacy for treating mild depression. There's a couple different active compounds. One of the main one is going to be hypericin, which actually works to inhibit monoamine oxidase, the enzyme. And then some of the other components may actually work to inhibit the reuptake of monoamine. So kind of a couple of different mechanisms going to work very similar to a lot of our current antidepressant drugs. So again, some of the adverse effects you might imagine to see with things like dry mouth, dizziness, confusion. Some patients might actually have an allergic reaction to this, so something to certainly consider. And then one of the huge things we see with this is that it's actually going to be an inducer of CYP3A4 P-glycoprotein. So if something is metabolized by CYP3A4, or if something relies on efflux transport by P-glycoprotein, or PGP, this means that it's going to have increased drug levels within the body. So again, this includes things like your HMG-CoAs reductase enzymes, like your statins. This is also going to cause issues with other things like your non-dihydropyridines and whatnot. And not only that, but we can also see some serotonergic toxicity that occurs, especially if it's being mixed with other antidepressants. So this is why it's critical to make sure we get a good history from your patients to find out what they're using to treat their depression. Because a lot of times people will not think of these herbal supplements as being drugs. And so, you might say, well, what medications are you currently taking? And St. John's wort never comes up. And then all of a sudden, you prescribe an antidepressant, and now they're having serotonergic toxicity. So again, very, very important to get a good history on these patients. And then looking at special populations, the elderly oftentimes are an overlooked population, but we certainly see increased suicidality, especially at patients greater than 65 years old. Again, important to do a thorough medication history because we need to find those pharmacokinetic and pharmacodynamic interactions that occur there. And because, again, they have a less physical reserve, especially in the older patients, you're going to see a higher risk for adverse effects. So again, orthostatic hypotension, weight gain, all these things can be more pronounced for these elderly patients. In pediatrics, we see that depression is probably a little bit more prevalent than we once thought, which is unfortunate. And unfortunately, we don't have as good a data, as good studies in the use of these medications in these children. Currently, fluoxetine is the only drug that has an indication from the FDA for depression, treatment of depression in kids less than 18 years old. Certainly seen other agents being utilized. And again, remember that black box warning for increased suicidality in younger patients. Looking at pregnant and lactating patients, we do see around a 14% incidence of serious depression during pregnancy. And again, mothers on SSRIs prior to the pregnancy are probably more likely to relapse during pregnancy. Again, lots of hormones floating around, just more prone to have this occur. And then what we've actually seen is that mothers on SSRIs during the pregnancy may be more likely to have underweight babies and may have some issues with the pulmonary system. So again, kind of have to weigh the risk versus the benefits, because again, if the mother has such severe depression that she tries to commit suicide, obviously the baby's not going to survive that. So kind of have to weigh the risk versus the benefits and decide whether or not it's worth trying. But again, there's going to be lots of long-term studies just waiting to come out as these children get older, because there's certainly going to be a bigger and bigger percentage of babies who have had some SSRI exposure during pregnancy. So it'll be interesting to find out what kind of the long-term ramifications are down the road. So again, looking at therapeutic considerations, it's probably a good idea to start with an SSRI or potentially one of the newer agents, and then go from there. If one SSRI does not work, you can potentially try using another one in the same class, or try utilizing one of the more miscellaneous agents. And the TCAs are generally not preferred due to their adverse effect profile, and monoamine oxidase inhibitors are generally used as a last resort. So again, they're the most severe in toxicity, don't want to use them. TCAs kind of as a second to last resort, but generally you'll see TCAs more often being utilized for things like PRN for sleep or neuropathic pain than ever for depression. If a patient experiences failure, some things to look for would include assessing their compliance, making sure they're having adequate duration of therapy, so make sure they actually waited that full 6 weeks before saying, hey, this stuff doesn't work, and also looking at appropriate dosing. And again, like I said, you can switch between agents in the same class or in a different class. So just because they failed sertraline doesn't mean they're going to fail fluoxetine. Again, could all change. Different patients are going to have different pharmacogenetic differences, and we just don't know enough about it to say definitively which one they will or will not respond to. And again, depending on the agent, make sure you're having an adequate washout period prior to starting a new agent. Again, if it's a shorter half-life agent, you can start within a day or two. If it's a longer acting agent, you may need to wait up to a week. So again, look at your pharmacokinetic profiles. And then also you may need to look at additional therapy. Do they have bipolar disorder? Do they need to potentially have an atypical antipsychotic put on board? All things to consider. You've treated the depressive symptoms, but maybe you still have some underlying disease states you still need to look at. So, we'll see if there's any questions on depression. Again, please feel free to send them to me. I'll also keep moving along and talk about anxiety. Just kidding, we're actually going to talk about bipolar disorder. Hopefully that did not give anyone anxiety. So we know that bipolar disorder is a chronic and oftentimes severe cyclic mood disorder. Oftentimes will have very recurrent fluctuations in both their mood, their energy, and also in behavior. And so it really differs from unipolar depression by including these manic, hypomanic, or mixed episodes that occur. And very often it's going to be a lifelong illness, so it's going to require both pharmacologic and non-pharmacologic therapy in order to help manage this long term. While the etiology is unknown, we believe that there are lots of different factors, including both developmental, genetic, neurobiologic, and psychological factors that all go into determining if a person will have bipolar disorder. Some even think that it may be due to kind of this altered synaptic or circuit functioning rather than specifically related to any one specific neurotransmitter. Clinical presentation, again, they have a history of mania or hypomania, not related to a specific cause or substance. Again, you got to definitely rule out things like substance abuse and whatnot. Again, you'll see lots of different varieties of bipolar disorder. I won't, leave it to your other classes to kind of get you into more of the details of this, but leave it to say that these episodes can definitely vary in length, frequency, and severity depending on the type. Again, other things to look at, many causes for mania, lots of things like CNS disorders like tumors or stroke, infections, endocrine disorders, especially from my side of things, from the drugs. You can certainly see things like alcohol intoxication or withdrawal can all appear as manic episodes. Certainly hallucinogens, steroids, everyone's heard of roid rage. All of these can kind of masquerade as a manic episode. Certainly not the same as a true blue, psychological disorder mentioned in the previous slides. So what we're going to be looking for in terms of therapy is we want to help eliminate the current symptoms, hopefully have a complete remission of those symptoms. We want to help prevent the recurrence of them, have them return back to their baseline psychosocial functioning. And as far as the therapy goes, I like to try to maximize adherence, minimize the adverse effects, which again can be dependent on the type of drug we're utilizing. Hopefully, if they have any kind of contributing substance abuse issues, try to help manage that. So whether it be alcohol, stimulants, whatever their drug du jour is, try to manage that aspect of it. And then try to avoid any stressors or substances that can help to precipitate an acute episode. Therapy for this is really going to be individualized. It's going to be different for every patient because the episodes are really going to be varying in frequency and severity between patients. And so that's why it's really important to look at treating both from a pharmacologic and non-pharmacologic therapy to help maintain remission of symptoms. Basically, though, patients generally are going to end up on a mood stabilizer, something like lithium or valproate, for their lifetime. And then medications can be added on kind of ad hoc for more acute exacerbations or acute symptoms. Again, looking at non-pharmacologic therapy, it's going to ensure, looking at things like ensuring they have adequate nutrition, sleep, exercise. They can also look at things like mood charting to actually identify the episodes, maybe look for trends or patterns that precipitate them, and also supportive counseling, psychotherapy. All these things can be useful for that. More frequently, though, we are going to require drugs. And so one of the first medications that we had for the treatment of mania was actually lithium. Actually, lithium used to be in 7-Up. So this actually be called the lithiated lemon soda. So if you ever had a manic episode, maybe just pop a 7-Up and you'd be feeling much better. Actually, it led to some toxicity, so not too great. But, however, we did realize that as early as 1949, it's a decent treatment for mania. Unfortunately, we don't have a really good theory for its mechanism of action. Some people believe that it can help to modulate gene expression, maybe has some neuroprotective effects. All we know is that it's very, very effective for treatment of bipolar disorder. Fortunately, it has a lot of toxicity associated with it, as we'll talk about in just a little bit. As far as the kinetics go, this is a small cation. It looks very similar to sodium to the body, so it's managed as such. So it's well absorbed throughout the body. is distributed throughout the body with no protein binding, and is not really metabolized to any degree. It is going to be excreted basically unchanged in the urine. As we'll see, anytime that the body is in a state where it wants to hold on to sodium, it's going to hold on to lithium. And anytime it's in a state where it's trying to get rid of sodium, it's going to get rid of lithium, which can be very important when looking at things that can change our levels of lithium. So lithium is still considered to be one of the first-line therapy for mood stabilization. Efficacy can sometimes be delayed up to several weeks, but fortunately, it's able to help prevent it's able to prevent manic episodes and help to reduce the suicide risk with these bipolar patients. Now, this is going to be one that has therapeutic drug monitoring associated with it, so serum monitoring is going to be critical for treatment success. Again, looking for both too low levels for subtherapeutic efficacy versus looking for way too high levels where we're going to have a lot of toxicity associated with it. So kind of the magic number to be shooting for is somewhere between 0.5 and 1.2 milliequivalents per liter. Notice here, similar to like sodium, the measurements in milliequivalents versus something like a valproic acid or other drug levels where you actually do something like micrograms per ml. So a little different there. One thing we do see is that with abrupt discontinuation can actually lead to remission of symptoms. And we also see some efficacy when combining lithium with other mood stabilizers, but by doing that we're also going to increase our side effect profile. So anywhere between 1/3 to 93% of your patients will experience some adverse effect from utilization of lithium. We know there's going to be both acute and chronic problems that are going to crop up here. So again, a lot of the adverse effects are going to be dose related, especially at peak serum levels. So the time that the drug is peaking in the bloodstream, we're going to see a lot of the problems with it. So again, most often you'll see this occurring 1 to 2 hours post-dose. So GI distress is going to be fairly common. Also within the GI tract, you can see some osmotic diarrhea. Because again, this is an ion, it's able to draw water into the GI tract to cause diarrhea. Also see some muscle weakness, lethargy, and then polydipsia and nocturia. So similar to how you would see if you had too much salty food. Again, this acts very similar to salt or sodium. So again, it can draw water into the body and give you that, or actually activate that thirst reflex in your brain to try to get you to drink more water. Some of the chronic effects we're going to be seeing with lithium is this fine hand tremor. This can happen up to 50% of patients. So again, it's pretty noticeable if you ever see it on a patient who's been on lithium for a long period of time. Some of the things we can do to help prevent this is to potentially use long-acting formulations. By doing that, you prevent rapid increases in their serum levels. Again, it'll be a little bit more of a gentle plateau versus a big peak. And then there's a possibility that utilization of beta blockers can help prevent some of these tremors from recurring. So similar to how you can utilize a beta blocker for things like performance anxiety when you're trying to calm your hands a little bit, so to be able to help with lithium-induced tremor. Other things we can see include a nephrogenic diabetes insipidus. So again, cause all kinds of electrolyte and water imbalance issues, but this can end up being treated with loop or thiazide diuretics. And really, during this time period, you got to watch your lithium and potassium levels because you will be losing a lot of that as you add on diuretics. We can also see some nephrotoxicity, so either interstitial nephritis or glomerular sclerosis, and then hypothyroidism. We'll see that lithium actually interferes with thyroid hormone synthesis and can lead to hypothyroidism, which could potentially worsen their depressive symptoms, cause all kinds of secondary problems. Chronically, we can also see some cardiac effects, so you can see T-wave flattening, inversion, AV block or bradycardia. You can also see some dermatologic effects, so things like acne, dermatitis, and we can also see weight gain associated with that, and then some CNS issues with slurred speech and ataxia. At overdose, we see lots of issues that can crop up, but a lot of it depends on whether or not the patient has been on the drug previously or not. So the idea of whether or not this is an acute or chronic ingestion. So people with an acute ingestion, so not too recently I've had a patient who came into the emergency department who had taken her sister's lithium. So again, this is the first time that it happened. And so because of the fact that this is a small charged ion, it does not cross the blood-brain barrier very easily, at least initially. So because of that, she did not have a lot of CNS buildup of the drug already, and so you saw a lot more GI effects than more than anything. Whereas someone who maybe had been on lithium for a long period of time and say maybe had some decrease in renal function, because again we know this is going to be dosed or eliminated entirely by the kidneys. So if you don't account for decreases in kidney function over time, you can certainly see super therapeutic levels. They oftentimes are going to have more CNS issues that pop up, which include things like seizures, coma, and even potentially some dysrhythmias as well. Looking at drug interactions, there are many that can occur with lithium. Again, anything affecting fluid status or affecting sodium can affect lithium levels as well. So this would include dehydration, sodium restriction, vomiting, diarrhea, heart failure, or even cirrhosis can all lead to drug accumulation. So your levels would be too high and end up getting toxic. Lots of drugs can cause lithium to accumulate, and again, this is all related to causing your body to try to hold on to more salt. Again, where salt goes, lithium follows. And so thiazide diuretics, NSAIDs, and ACE inhibitors, along with salt restriction, can all lead to your body trying to hold on to more sodium and thus hold on to more lithium. Again, this drug is not metabolized, so fortunately there's no CYP drug interactions we'd have to worry about with this. So beyond lithium, there are also several anticonvulsants that we can utilize to treat bipolar disorder as well. One of the first ones that is kind of one of the more mainstays of bipolar disorder therapy is going to be valproic acid. There are several brand names, but it can include Depakote or Depakine, Depakine even. This is actually an organic solvent, but later was realized to have some decent anticonvulsant actions. And now, because of its side effect profile and efficacy for treatment of bipolar disorder, it is the most prescribed mood stabilizer in the U.S. Again, it's good for acute mania, or can be utilized for chronic therapy as well. And while we don't have the exact mechanism totally down, it's thought to either mimic GABA, which again we know as the major inhibitory neurotransmitter, or thought to increase the activity at postsynaptic receptor sites. And like we mentioned before with lithium, that you may have some synergistic actions when combined with other agents, but that also is going to increase our risk for adverse effects. Common things we'll see with valproic acid are going to include GI distress. You can see some fine hand tremor, but certainly not to the same degree as you would see with lithium, and also sedation. Especially as levels increase, we can see issues with ataxia, lethargy, and potentially even hepatotoxicity. This is another one where you're going to see therapeutic drug monitoring being utilized to help ensure you're reaching a therapeutic level without getting too toxic. So the therapeutic range for valproic acid, it kind of changes depending on what source you look at, but in general, anywhere between 50 to 125 micrograms per ml would be considered a therapeutic range. Very similar levels to what you would see for as an anticonvulsant. Other things to look for with monitoring would include both baseline and follow-up hepatic function tests due to the risk for hepatotoxicity with this drug. Another anticonvulsant commonly used to treat bipolar disorder would include carbamazepine or Tegretol. This one's interesting because it's structurally similar to the TCAs, but you don't see quite so much toxicity as you do with those other agents. Again, the exact mechanism for mania is not fully elucidated. We know that carbamazepine affects a lot of different types of receptors, and the way that it works as an anticonvulsant is actually by inhibiting the neuronal sodium channels. So again, doesn't necessarily make a whole lot of sense for why it works for mania, but we do know that it does work. Again, this is not going to be a first-line agent, but it can be useful for patients who are refractory to lithium. Carbamazepine also requires therapeutic drug monitoring. This one has a therapeutic range of between 4 to 12 micrograms per ml. And adverse effects would include things like GI disturbances, ataxia, lethargy, nystagmus, and potentially even seizures in very high levels. So usually greater than 20, you'd start to worry about things like seizures. Due to the fact that it blocks sodium channels, we can see this effect on the heart itself, so it can cause some conduction disturbances, potentially cause arrhythmias. And one of the other things we would worry about is it causing an SIADH, or a syndrome of inappropriate antidiuretic hormone secretion. Basically, it can kind of wreak havoc with sodium levels, causing hyponatremia. And again, if you can imagine utilizing this with lithium, that's also going to cause problems with your lithium levels as well. Some of the more common drug interactions you'll see here is that it actually induces CYP3A4. So this may actually cause other anticonvulsants to be more rapidly metabolized, making them less effective. And it can also make your oral contraception less effective. So it's important to counsel patients to utilize a backup method of birth control while on carbamazepine. Not only that, but if you were to utilize carbamazepine on top of valproic acid, you would also see a drug interaction where valproic acid will displace carbamazepine from serum proteins. By doing that, you can see increased free fraction of carbamazepine and more chance for toxicity. Similarly related to carbamazepine is going to be oxcarbazepine, or trileptal. Again, this is a derivative, and again, we don't know the full mechanism for how it works for mania, but certainly works for seizures by blocking sodium channels. We have less data on this, so it's not going to be as well recommended as some of the other agents we've seen so far, and there's no therapeutic drug monitoring associated with it. Some of the adverse effects are going to include things like dizziness, sedation, headache, and ataxia. There's going to be some GI disturbances associated with it, and actually what you end up seeing with oxcarbazepine is more instances of SIADH than even carbamazepine. As far as interactions go, you're going to see that it inhibits 2C19 and still induces CYP3A4, similar to carbamazepine, so all the drug interactions that go along with that are going to be present here as well. Another anticonvulsant that can be utilized for bipolar disorder would include lamotrigine or Lamictal. Again, this is going to work similar to the other agents by blocking sodium channels, but also has the activity of inhibiting glutamate release. And similar to how GABA are kind of the brakes on the system, slowing down neuronal transmission, we see that glutamate is an excitatory neurotransmitter, so it's kind of like the gas on the system. And so by inhibiting glutamate release, again, this is how it works as an anticonvulsant agent, but we don't necessarily know how it works fully as a anti-mania agent. But we do know that it has both antidepressant and mood stabilizing effects, which can be beneficial for our patients. One of the notable drug interactions we can see is that if it's used with valproic acid, it will actually end up decreasing the clearance of lamotrigine. It can more than double the half-life. So it's one of those things where if you are adding on valproic acid to a lamotrigine regimen, you should decrease the dose of lamotrigine by half, or if you're starting up lamotrigine on a patient who's already on valproic acid, probably start at half the dose you normally would in order to help prevent this drug interaction from occurring. Some of the adverse effects we can see here are going to include things like drowsiness, headache, and tremor. Rash can be much more commonly seen with lamotrigine than some of the other agents. Up to 10% of patients are going to end up discontinuing therapy due to this rash that can occur. And then when you have valproic acid on, especially if you did not take into account the drug interaction, and the levels are high, you're going to see more diffuse rashes. You can potentially see mucosal involvement or fever, with kind of the end point being potential for Stevens-Johnson syndrome. Again, we know it's a very severe skin reaction, which can be fatal if not caught early and treated aggressively. We also know that antipsychotics can be utilized to treat the symptoms of mania. We'll talk more about this in the next section, but there's basically two generations of antipsychotics. The first one really worked to block specifically the dopamine 2 receptor, whereas the second generation agent are going to block dopamine 2 and also serotonin 2A receptor. When treating acute mania, we see that they are effective either as monotherapy or in combination therapy, and especially for patients who have more of a component of agitation, aggression, or psychosis, these antipsychotics are going to be especially useful for treating those patients. You don't necessarily know all of the ins and outs of long-term therapy, especially with some of the chronic adverse effects they can run into, including things like dyslipidemia and weight gain and type 2 diabetes, but certainly for acute mania, these can be useful agents. As far as adverse effects and drug interactions go, there will be certainly more to come in the next lecture section, so we'll get to those when we get to them. We'll also look at some alternative agents that can be useful for bipolar disorder. Benzodiazepines, again, these are going to be things like lorazepam, midazolam, diazepam, all these other benzodiazepine agents. They're going to be useful for acute mania, agitation, panic attacks, and insomnia. We'll talk more about these when we get to the anticonvulsants and also the anxiety section. But for patients who can't tolerate mood stabilizers, these might be good alternatives. Again, we'll talk more about those in just a bit. We have also some calcium channel antagonists. So we've talked about these before in relation to antiarrhythmics and antihypertensives, but there might be some evidence to show they could be useful for treating acute mania. They're thought to inhibit neurotransmitter release and perhaps even synthesis. And then verapamil itself may have some mood stabilizing properties. Nimodipine is a dihydropyridine calcium channel blocker that's able to penetrate the blood-brain barrier very well. It may have some anticonvulsant properties. In general, when treating bipolar disorder, it's good to start with a mood-stabilizing agent. So again, start with something like lithium, carbamazepine, valproic acid, or a second-generation antipsychotic. If they're having a lot of insomnia, anxiety, or agitation, you can definitely consider adding on a benzodiazepine. Oxcarbazepine is generally going to be an alternative agent once some of these other ones have failed. If they have inadequate response to your initial therapy of monotherapy, you could potentially utilize combination therapy. So maybe lithium plus an anticonvulsant, or lithium plus a second-generation antipsychotic, or maybe an anticonvulsant plus a different anticonvulsant. So maybe like valproic acid and carbamazepine, or utilize like a second-generation antipsychotic plus an anticonvulsant. So lots of different options, and again, it's really going to be tailored to patient specifics. You need to find what works for your patient, what they're going to be able to tolerate, because I will tell you that adherence is a big problem with a lot of these agents for these bipolar patients, especially when they get into a manic phase and they think they're great, and a lot of people like their manic phases and may not want to take the medications when they're at that point, so it can be a big problem with compliance. So I will take any questions, specifically if you want to hold them till Monday for us to talk in person, that'd be great. We'll be covering the rest of the behavioral section. I'll probably have to break that one down into 2 lectures, and then we'll have a review before the first test. I'm sure I'll get the question whether or not therapeutic levels are going to be on the test, and I believe those are going to be fair game. So because they are very important to remember when treating these patients, and it's good to have these numbers in mind now before heading out into the clinical world. So anyway, if you have any more pressing questions, please send them to my email address, and otherwise I will see you guys on Monday. Thanks so much.